Japan, in the United States, meaning that generally the waiting time to see psychiatrist for the first time will be 2 months or 6 months, sometimes long. And also you need to have a more co-payment and have to arrange with the insurance company. But it may not apply to people in Myanmar. As a matter of fact, I have a friend, my classmate, Dr. What's his name? Zo Sein Nguyen. He was my classmate, and he used to be a superintendent of the Dargali Wadi, the hospital, psychiatric hospital. I don't think you have to wait that long to see him and other psychiatrists in Myanmar. I want to encourage to provide treatment for the patients who come to you with the anxiety and depression. In the next page, I'm going to talk about which illness in psychiatry you should treat and which one you should consider not to treat, and some of the conditions you should not treat at all. The reason I encourage for the non-psychiatrist physician to treat depression and anxiety, because the first line of medication for both conditions is SSRI, like a fluoxetine and paroxetine and sertraline, because they improve the symptoms 60% of the time, and they resolve the symptoms 30% of the time. So 1/3 of them totally get cured, but they have to continue medication, and 60% show improvement of the symptoms. But before jumping into the medication, you have to ask them how much of these anxiety and depression are interfering with your life. For example, sleeping, concentration of the job, losing temper quickly, problem going through daily activities like childcare and household chores. If they are markedly interfere with these functions, you will need to start medication. Otherwise, here that usually psychotherapy will help to alleviate the symptoms. But what happens in Myanmar, there are not many therapists I know of. So maybe you should think about studying SSRI, like fluoxetine 10 milligram or 20 milligram, or paroxetine 20 milligram, or sertraline 50 milligram to start with. And you need to adjust the dose. Most likely, fluoxetine and paroxetine, they don't need to adjust the dose, but sertraline may need to adjust the dose. And the other are citalopram and S-citalopram. Okay, condition. Now I'm going to come to the symptom later about the depression and anxiety. First, I want to encourage you to treat with the title of condition you should treat. Initial, when they come to you, mild to moderate depression or moderate anxiety or dysthymia. I'm going to define the dysthymia later part when I come to the symptom of depression. It's a mild type of depression, but much longer time that they are recognized. For maintenance therapy, the people who are already treated for schizophrenia or bipolar, if they're stable, you should continue to treat. And maybe you can adjust the medication, but if the patient became acute, you should refer them to either the hospital or a psychiatrist. And major depression in full or partial remission, stable PTSD and ADHD. So I'll come to the PTSD and ADHD symptom also later. So these are the conditions you should treat. And conditions you should consider not to treat, because these may be difficult conditions to treat. Severe anxiety, panic disorder. I'll come to the criteria later. Unstable schizophrenia or any other psychosis. If they're acutely psychotic, you should not treat. Refer them to psychiatrist or psychiatric hospital. Unstable bipolar disorder. You should not start treatment for PTSD and ADHD on your own. The psychiatrist should start the treatment, PTSD and ADHD. When they are stabilized, you should continue to treat. condition to avoid at all. Acute depression with suicidal thought, suicidal plan, and acute psychosis, and acute manic state, you should not treat them. If you treat them, it will be very difficult to manage and control the symptoms. Now, this is what happened in the United States. It may happen in other parts of the world also. Here, overutilized diagnosis. There are 4 diagnoses frequently overutilized. Both primary care physician and psychiatrists randomly they use this diagnosis for the treatment. Bipolar disorder. Not every mood swing is bipolar. I'll explain to you what later. ADHD, attention deficit hyperactivity disorder. Borderline personality disorder, I think, is very rare in Myanmar because this is a culturally linked to the cultural background. PTSD, again, this may be linked to cultural background also. And these are, I'm showing you about 7 symptoms. Not every diagnosis has all the symptoms. They have 3 or 4 of them. Impulsivity, irritability, hyperactivity, distractibility. These are symptoms of bipolar and could be symptoms of ADHD and borderline and PTSD also. These are the 7 symptoms that mostly related to overusing of the diagnosis. I want to tell you that I work at the inpatient general hospital, and people come to me, they always say that I am bipolar disorder because my doctor told me I'm bipolar, or my friends told me I'm bipolar. Because I want to tell you that 80% of the people who came to tell me they are bipolar, they are not bipolar. Maybe about 20-25% of them are true bipolar disorder. Because of the depression and anxiety, they have thought raising, they have irritability, they have mood swings. As I said, every mood swing is not bipolar disorder. ADHD also. ADHD usually started in childhood or younger life, but sometimes I see that patients who are 40 years old, they started with psychostimulant for ADHD. They are quite not appropriate for the treatment. People call people bipolar, borderline personality disorder when they don't like the patient usually. Okay, now bipolar disorder. Mania. There are several symptoms described: increased self-esteem, grandiose ideations, decreased need for sleep, pressure speech, means that they talk so fast that they can stumble on their own speech, flight of ideas, distractibility, excessive pleasurable activity like buying spree. They bought things on the credit card with the money they don't have. Sexual indiscrimination, they sleep with whoever they meet in bar or social activities, foolish investment. Symptoms, according to the criteria, symptoms should last 1 week. But even if they last 3-4 days, it's okay to diagnose it by mania, but not a few hours or a few minutes. Sometimes they come and tell me that I am bipolar disorder because 1 minute I'm happy, another minute I'm sad. This is just maybe general mood swing, but not the true bipolar disorder. I want to tell you that hypomania and mania, the symptoms are exactly the same, except the severity is different. What you can just distinguish between bipolar, mania, hypomania is there are three things you need to remember. One is hypomania, they never have psychosis, never have delusions, or never have hallucinations. Mania, people don't sleep for several nights. Visual hallucinations, they start to see things, is very quite common in manic episodes. The second one is they cannot function. They cannot do their work. They cannot do their household chores. People hypomania, they still go to work. People can see that he's quite grandiose, quite high, speech is a little bit fast, but they don't interfere with their daily life. but people can notice that he has a hypomania. Third point is the need to hospitalize because of the mania. Hypomanic people never or almost never require hospitalization. Borderline personality disorder. As I said, this is culturally related. Here, a lot of people are borderline. They will start to show their symptoms, especially when they are hospitalized. I don't see many people in Myanmar have the borderline personality disorder. They feel abandonment, chronic feeling of emptiness, inappropriate intense anger, unstable intense interpersonal relationship, persistently unstable image of sense or sense of self, impulsivity. They cut themselves, they hit themselves on their face. A lot of patients, regardless of such gesture or self-mutilation, they don't really try to kill themselves, but they try to hurt themselves, cutting or stretching or hitting themselves. Irritability. Sometimes they have transient paranoia, not persistent delusions. PTSD, post-traumatic stress disorder. Not every people exposed to traumatic experience has developed the PTSD symptom. It depends on how they manage from the beginning after the traumatic event stopped. A lot of people here were sexually abused when they were a child. Sometime later in the life, they develop these symptoms of PTSD. Abuse, physical abuse, emotional abuse. It can cause the development of the PTSD symptom. But there are a lot of people that I have seen, they have really traumatic events, like a girl gang raped at the age of 16. She was okay. So far, what I saw her, the other symptom, but not the symptom of PTSD. Their flashback, nightmares means the nightmare about the traumatic event. They try not to talk about this. They try, even to the psychiatrist, they cannot reveal in detail because they don't remember sometimes. Sometimes it's very painful to talk about this and to come to the awareness. They have persistent belief that they are bad because of, they usually think that PTSD, the event happened because of their mistake, because they're bad. Hypervigilant means that they reacted to some stimulant quite inappropriately. They're typically concentrated, reckless or self-destructive behavior. Maybe they are driving with high speed in the car, or they are drinking excessive alcohol and self-destructive behavior. Feeling of detachment. Sometimes they feel that they are not attached, they are not part of the wall. They are outside of the wall. Irritability, exaggerated startle response, meaning if you touch them, they jump up. That's exaggerated startle response. As I said that the veterans, war veterans also has a lot of PTSD, but sometimes they want to get benefit, they fake the PTSD symptoms. That we have to try to differentiate in the forensic psychiatry, we have to try to differentiate between fake PTSD and the real PTSD to give them benefits. ADHD, there are two parts of ADHD, attention part and hyperactivity part. Attention problems can be caused by depression or other psychiatric problems. Hyperactivity belong to ADHD. In the children, you can see that they're literally climbing the wall. They cannot sit still. They're jumping all over. But the attention problem, a lot of people get treated for ADHD at the age of 40, 45 because of attention problem. You got to ask them, how do they do in the school, high school, if they go to college, and how do they do in college? If they do very well in school, most likely they are not ADHD. Because ADHD people cannot focus, cannot concentrate, they cannot follow through the rules, they cannot sit still, They can ask questions, they can give you answer before you finish the question. And hyperactive people, they cannot sit still, they cannot sit in the seat, often runs about somewhere, and literally you see the people climbing the wall. That they talk excessively. They often interrupt or intrude other people. I'm not sure how much of the children in Myanmar have ADHD. ADHD, the treatment with psychostimulant like methylphenidate, those medications are strictly controlled in the United States, but they're still abused. They have tendency to abuse these psychostimulants because people who are depressed, who are they want to get high, so they buy the psychostimulant from the street. Now, okay, major depression. Major depression, the book said that according to criteria, you have to have at least of symptom of these major depressive symptoms, or at least 4 or 5 of them. But if the patient has even 4 or 5 days or a week of these symptoms that interfere with their living, functioning, then you can diagnose a major depression. As I said, even major depression or even close to major depression, you can start the SSRI type of medication. I'll come to medication in later part. Depression is depressed most of the time, nearly every day, marked diminished interest, pleasure, significant weight loss or weight gain, more than 5% in 1 month. Some people, depressed people, overeat. Some people don't have appetite. Some people came to the hospital losing 30 pounds in about 2 months, which I see quite often. But atypical depression, they tend to eat more and they gain weight. Insomnia or hypersomnia almost every day. They either cannot fall asleep or they cannot get up, so they're too tired to get up. Psychomotor agitation or retardation. Fatigue or loss of energy almost every day. Feeling of worthlessness and excessive inappropriate guilt. Some of the patients that they feel guilty what they have done 30 years ago, 20 years ago. These are not appropriate guilt. Something happened to himself, herself, or something happened to his family member. He may have made some minor, insignificant mistake, but they make a big thing and became guilty, causing depression or contributing to depression. And the diminished ability to think or concentrate, recurrent thought or death, or suicidal thought or gesture. And dysthymia is similar symptom, but at a low grade thing, but and there's no suicidal thought in dysthymia. They have to be existed for 2 years for low grade depression to cause dysthymia. Still, the treatment is with the SSRI, the first line drug. Generalized anxiety disorder. Excessive worry for at least 6 months. The person finds difficult to control the worry. The worry anxiety associated with at least 3 of the following: restless feeling on edge, easily fatigued, they get tired so easily, difficulty concentrating, irritability, muscle tension, difficulty falling or staying asleep. These are generalized anxiety disorder. And panic disorder, periods of intense fear or discomfort symptoms develop abruptly. It can last for a few seconds to a few hours. They sometimes came without any precipitating factor. Sometimes they have some precipitating factor that they reacted with panic symptoms. Palpitation, chest pain, discomfort, trembling, sweating, feeling of choking and sense of shortness of breath, nausea or abdominal distress, feeling of dizzy, fainting, lightheaded. Derealization, depersonalization means that They think that the world around them are not real, they're fake. Fear of dying. A lot of people have, during the panic attack, they're afraid of dying, they cannot breathe. They have palpitation, chest pain, fear of losing control or going crazy. Paresthesia, chills, and hot flushes, even they have physical symptoms. In my experience, over 40 years, panic symptom is the most difficult to treat symptom. Psychosis, they can resolve it. Acute depression, they will be in remission. Panic disorder, unless you use a high dose of benzodiazepine group of medication, sometimes they don't get better. And as you know that the benzodiazepine group of medication, they develop the tolerance. Over time, if you start with alprazolam, 0.5 milligram twice a day. 2 years later, they may need to take 1 milligram 4 times a day. So it is very difficult to treat panic disorder. It's difficult to get into remission. Here, you have to combine medication with psychotherapy. Now, the medications. Antidepressant medication. There are several classes of antidepressant medication. SSRI, selective serotonin reuptake inhibitors. These are considered first-line drugs. Before I go there, I want to tell you that all the antidepressant medication, either SSRI, SNRI, tricyclics, tetracyclic, or dopamine norepinephrine blocker, or monoamine oxidase inhibitors, they all efficacy is the same. If you look at the literature, the improvement rate and resolution rate, they are the same. The reason SSRI is chosen because of the side effects, the less side effects. Still, they have serious side effects still, even though they are less side effects than tricyclic. When I was a resident, the only antidepressant we have back in the 70s is a tricyclic medication until fluoxetine, Prozac, came to the market in 1988. So we had no choice but to use only tricyclics. So the tricyclic has much more severe side effects, like mostly caused by anticholinergic effect, dry mouth, palpitation, constipation, and also has EKG changes. ECG changes with the prolonged UTC. These are the, and also you can take a month of SSRI, people don't die. But if you take 15 days of tricyclic, patient may die. So they are more lethal in low doses, tricyclics, compared to other type of antidepressant medication. So SSRI has fluoxetine, paroxetine, citalopram, S-citalopram, and sertraline. And then a new one came out later called SNRI, selective serotonin and norepinephrine receptor blocker inhibitors. They are venlafaxine, desvenlafaxine, and duloxetine. The difference between venlafaxine and duloxetine is venlafaxine, when you start at usually the 75 milligram a day, after increase to up to 150, they act like SSRI. Above 150, they act like norepinephrine blocker, just like a tricyclic. On duloxetine, they block the serotonin and norepinephrine at the same time together. But anyway, all these medications, you start at the full effect is not realized until about 2 weeks. And tetracyclic is also a kind of SNRI because of mirtazapine. They block the serotonin and norepinephrine at the same time. But according to the studies, duloxetine block the norepinephrine more than serotonin, and tetracyclic mirtazapine block the serotonin more than norepinephrine. Mirtazapine have been used for in PTSD. They reduce anxiety, they improve sleep, but they cause a lot of weight gain. The same thing as SSRI. They have weight gain problem. They have a gastrointestinal symptoms as a side effect. And when the fluoxetine first came out in 1988, they tested at 5,000 or something like 20,000 people. They didn't see the sexual side effect. Only after a couple of million people using, they reported sexual side effect. The failure to achieve the satisfaction as a sexual side effect. And dopamine norepinephrine blocker. The only one, bupropion. Bupropion, they block the both dopamine and norepinephrine. Dopamine is a pleasure chemical. Depression is caused by reduced dopamine, reduced norepinephrine, and reduced serotonin. But too excessive dopamine causes psychosis. Again, dopamine, they call it pleasure chemical. And when you use cocaine or smoke cigarettes, you increase the dopamine. That's why people who smoke cigarette, it's hard to get off from the cigarette because they give in some pleasure chemical to them. Bupropion, that's why we use it for people who are depressed, who are on cocaine and smoking. As a matter of fact, high dose of bupropion are prescribed for smoke cessation here. But this is the only antidepressant that has no sexual side effect or no weight gain. But the problem is a tolerance problem. They increase anxiety, insomnia. We need to give them in the morning or not later in the day, not much later in the day. And they are contraindicated in seizure disorder because they lower the seizure threshold a lot, and ED disorder. I have seen people who took overdose of bupropion. They got seizure to the point that they crushed the spine. They permanently disabled. Bupropion also is dangerous to take overdose. The only one safe medication is SSRI type of medication. And tricyclic, I mentioned to you that imipramine, amitriptyline, doxepin, nortriptyline, desipramine. Amitriptyline, I think it was used for this to sleep. 10 milligram people, 10 milligram pill I saw in the Myanmar. I don't remember the trade name. Somebody remember the trade name? Amitriptyline. 10 milligram, doctors prescribe to sleep. Amitriptyline. Here, we use amitriptyline is used between 75 and 300 milligrams for treatment of depression. But again, the amitriptyline has the most side effect of sedation, constipation, blurry vision. Some of these amitriptyline and nortriptyline are still used by a lot of neurologists and gastroenterologists. Neurologists use for chronic neuropathic pain, amitriptyline. They usually use about 25 milligrams a day or 50 milligrams a day. Nortriptyline and doxepin, they can be helpful in irritable bowel syndrome by using their side effects. Now the latest trend is NMDA receptor antagonist. Let me see. And this is N-methyl D-aspartate. It is a kind of a group. It's similar to glutamate. They give it nasally. So for the treatment-resistant depression, now we started to use this called esketamine nasally. But after you give nasally, the patient will wait for 1.5 to 2 hours in the office because they can cause unexpected increase in blood pressure. Now they are also approved for treatment of depression, not only the treatment-resistant depression. MAO inhibitors rarely used now because of it quite dangerous. They also have a acute hypertensive crisis if they are combined with the SSRI type of medications. or they're eating Caribbean-rich food. Now the safer one is selegiline. That's it's the available in skin patch. They have a milder side effect than the older one, phenazine, tricyclomine, and isocarboxazine. When you switch from the MAO inhibitors to SSRI or SSRI to MAO inhibitors, you're going to wait 2 to 4 weeks. Generally 2 weeks, except fluoxetine. Because fluoxetine has a long half-life. So you need to watch out period for 4 weeks before you switch from SSRI to MAO inhibitors. MAO inhibitors are usually reserved for treatment-resistant depression also. They are not first-line or second-line drugs. A lot of time that now we use the augmentation therapy. Patients who are treatment-resistant for depression, we switch a couple of medications. Sometimes we combine 2 medications. For example, we can combine SSRI type of medication and bupropion, because SSRI will increase the serotonin. Bupropion will increase the dopamine and norepinephrine. So we can use 2 antidepressant medications at the same time. Or even if the combination doesn't work, you can add lithium, not high dose, maybe 300 milligrams twice a day. Lithium level is generally accepted as 0.6 to 1.2 milliequivalent per liter. But you can use a lower than therapeutic dose of for mania. You can use, it doesn't matter the level was. They can increase the efficacy of the antidepressant medication. Buscarole is generally an anti-anxiety medication, non-addictive anti-anxiety medication. We can use buscarole also. Usually the dose is between 10 to 20 milligrams. And the low dose of second generation antipsychotic medications, like we can add 5 milligram or 2.5 milligram of the olanzapine or aripiprazole 5 milligram, or thiopine 50 or 100 milligram at that time when the patient have problem with sleeping. Aripiprazole is used when the patient has low energy because it tends to increase the energy of the patient when you give them aripiprazole. If the patient doesn't respond to first or second antidepressant medication, you should consider combining two antidepressants of different kinds, or including you can combine tricyclic and SSRI, or you're going to use augmentation therapy. If available, you can use NMDA medication, esketamine, but I'm not sure it's available in Myanmar. It was only available here not too long ago. It's very expensive here, and that's why sometimes the insurance company do not approve. If the patient will pay from their own pocket, it's very expensive. Now the bipolar agent. The medication, the bipolar agent approved by the FDA, Food and Drug Administration, are lithium, valproate, that's a Depakote, carbamazepine, Tegretol, oxcarbazepine is the hybrid of carbamazepine, and lamotrigine. These are the approved by the FDA to use a bipolar agent, as a bipolar agent. As you know, valproate, carbamazepine, oxcarbazepine, lamotrigine, they are for people with a seizure disorder. They found it effective in controlling bipolar symptoms. Especially valproate is very good for people who are very aggressive, impulsive, cannot control their physical activities. The valproate is very good. But I will tell you what are the things that drawback of this medication also. And also lesser used, less effective, and not officially approved. Still, some doctors use pyruvate and gabapentin. The gabapentin is used for neuropathic pain and seizure disorder, and sometimes they use for anxiety. I saw a few cases that they were prescribed gabapentin for anxiety. But when you use a bipolar agent, you got to consider the following factors: lithium, valproate, and carbamazepine. You need to check the blood level. The first time, valproate and carbamazepine, you can check the level after 4 days of treatment. They stabilize, blood level is stabilized. Lithium stabilizes after about 10 days, but you can check 5 to 6 days later to see where that level is. But the stable state is not obtained until about 10 to 12 days of lithium. So when you use lithium, 10% has effect on renal function and morphology of kidney after 10 years. So you got to watch the renal function when you use lithium. And also sometimes it can cause hypothyroidism. So when the patient retreated with lithium, they start to show hypothyroid symptoms. You got to try to get thyroid TSH and also T3, T4 level to see that if they have the hypothyroidism caused by lithium. Valproate. The drawback of valproate is a weight gain, and it will affect the liver function. But extremely rare, the hyponatremia, the sodium level get very low. The most two common side effects are weight gain and liver function problem. Sometimes it can cause pancreatitis also. I've seen a couple of patients losing hair from valproate, but not very common. And carbamazepine has been out for a long time, even when I was a medical student. They have bone marrow suppression, as you know, and periodic blood cell count need to be done to ensure that they don't suppress the bone marrow to the dangerous level. And oxcarbazepine is a hybrid of carbamazepine. They cause hyponatremia in about 10% of the patient. You don't need the blood level of this medication. Given within the range, as they have mentioned, but you have to use a periodic check of the basic metabolic kind of like a basic electrolytes to see that the sodium level is not dangerously get lower. Lamotrigine is a new addition. Maybe it was out more than 10 years ago. Initially used for seizure disorder, and now they approve for the bipolar disorder also. They can cause the fatal Stevens-Jones syndrome-like rashes over the neck and chest, all over the redness, happening 1 in 1,000. When you use these medications, you got to tell the patient that if the rash happens, go to the hospital immediately to stop this reaction. One thing is that I don't mention here, but lamotrigine and valproate, they use the same enzyme. We rarely, almost never use it, rarely or almost never use valproate and lamotrigine together because of they share the enzyme, and you cannot use more than half the dose of each of them than regular doses. We combine a lot of time lithium and valproate together when the manic symptom is not well controlled. And when I used to work in forensic hospital, there's extreme cases of psychiatry in forensic hospital. We would sometimes use 3 of them: lithium, valproate, and carbamazepine. At that time, the only 3 available when I work at the forensic hospital. We use all of them, plus antipsychotic medication also, when the patient is psychotic. Now, antipsychotic medication, first generation, haloperidol, thiophene, fluoroprobenzine, fluphenazine, phenazine. Okay, we used to have a thioridazine, which is a straight chain also of phenothiazine group, similar to fluoroprobenzine, but they stopped it because of the pigmentation in the eyes causing blindness. So now we still use haloperidol a lot, and fluoroprobenzine a lot also. We also use fluphenazine and phenazine sometimes. I'll come to the long-acting medication from the first generation and second generation. Second generation, the groups of second generation, dibenzapine group started with clozapine. Clozapine is a very good medication. When I used to work at the quality psychiatric hospital, we have about 400 patients. With a criminal procedure patient, whether they are not competent to stand trial or they are found not guilty because of the reason of mental illness. Before clozapine, we have about 10 patients out of 400 patients. Doesn't improve with anything, whatever you do. When the clozapine came out, we used on all of them, and 5 were improved and they were discharged from the hospital. Still another 4 or 5 out of 10 patients, they don't improve at all. And olanzapine, quetiapine, and asenapine, they all cause the problem of weight gain, a lot of weight gain. Some people gain from, one of the patients gained from 150 pounds to 290 pounds in some of the medications. Even though they stop it, they keep gaining weight. Asenapine is the medication that causes least weight gain, and they advertise as the olanzapine without weight gain. That's what they advertise. Asenapine is the one to be given under the tongue to absorb under the tongue, not the pill. Benzoxazole. These are risperidone, zypresidone, paliperidone, iloperidone, and durasidone. They call it DONE group and PIN group. DONE group, they cause weight gain much less than PIN group, but still have their own individual problem, which I can come later. Especially risperidone cause a prolactin level increase. A man, did they develop the gynecomastia? Women, they started to produce milk even they are 50 years old or 60 years old. Zypresidone is very good medication, especially in bipolar disorder, but they cause serious UTC prolongation. Okay, now the partial T2 5-HT1A agonist and 5-HT2A antagonist. So the new medication came out, aripiprazole. The last one came out is brexpiprazole. They don't cause much weight gain. They don't cause any tiredness. Sometimes they have patient become quite restless and quite irritable. Sometimes that can happen. These are second generation antipsychotic medication. Now the long-acting injectable antipsychotic. We have 5 other available in the United States. I'm not sure how many available in Myanmar. The first one came out with fluphenazine decanoate. It can be given every 2 weeks or every 4 weeks. But usually after 3 weeks, the level probably goes down and patient symptoms start to show again. Haloperidol, once every 4 weeks. Aripiprazole Bentena, also once every 4 weeks medication. Risperidone Consta, every 2 weeks given. Paliperidone Sustena, every month. And now they have a paliperidone Trinza for every 3 months for the patient. These are given because the patients are non-compliant with medication. So they stop taking oral medication, and they need to come to clinic only once a month or once every 2 weeks to receive the intramuscular injection. But when you start the decanoate and long-acting medication, you got to start with the oral medication for 2 to 3 weeks to initiate the effect. Because these long-acting injectable medications, the effect doesn't start. They don't start until about 2 to 3 weeks. Risperidone is 3 weeks. The rest of them are 2 weeks. And you have to consider the following points. There are other minor points also, but these are the major points that I want to mention to you. All antipsychotic medication has similar effectiveness. Side effect is different. Tolerance for the patient is different. First generation antipsychotic has relatively more side effects, the same as first generation antidepressant medication, tricycle. That's why the drug companies, they try to make medication with a similar effectiveness with a less side effect. Diazepam group, as I mentioned to you, that olanzapine and clozapine has both sedation and weight gain. Sometimes we can use the sedation as a tool when the patient cannot sleep. For example, we use olanzapine is not that much sedation. Quetiapine is very much sedation. It's a sedating medication. Sometimes we get either augmentation for the antidepressant medication or for antipsychotic use, quetiapine then. Quetiapine is the only medication approved for bipolar disorder, bipolar depression, which I don't mention here. Bipolar depression is a complicated one, and psychosis. Excuse me. Risperidone increases the prolactin level. As I mentioned, it causes gynecoplastia in male and producing milk in female, either they are 20 years old or 50 years old. Paliperidone bypasses the hepatic pathway. It's good for the patient with liver problem. When they have a compromised liver function, they're psychotic. This is a choice of medication that you should consider using first. Clozapine requires periodic WBC and absolute neutrophil count due to bone marrow suppression. What we do here is, first, we start at 25 milligram a day, increase 50 milligram the next day, gradually increasing. We had to measure the CBC, WBC, and neutrophil counts every week for 6 months. After 6 months, every 2 weeks. After 2 years, once a month. If you don't do the blood level, we don't see the blood count, the pharmacist doesn't give you medication. Ziprasidone may increase the QTC. Pre-treatment ECG is recommended, but not required here. Always consider interaction with other medication based on cytochrome P450. I don't want to go into details, so this is so wide. You're going to look at them when you prescribe what cytochrome P450 metabolizes them, or their blocker, or they increase it. So based on that, if they're using the same cytochrome P450, you're going to use lower dose. If they are enhancing cytochrome P450, you'll use a higher dose of medication. Thank you for listening. I try to cover a lot of common psychiatric conditions and medication. If any questions, I will try to give you the answer.
Of course, sir. Thank you so much for the delivering the complete package. But I have something to clear myself about one fact. You clearly mentioned that the SSRI and the tricyclic antidepressant have the same efficacy, but I just want to know that, they have the same efficacy for...
Let me increase the sound.
Sorry.
It's just okay. Okay, go ahead, yeah. You're talking about...
I think it's just, okay, right. So you clearly mentioned that the tricyclic antidepressant and the SSRI they have same efficacy, but I just want
Yes.
to clarify myself about the fact that they have the same efficacy for depression, anxiety, or any psychiatric conditions.
Yes, both anxiety and depression, the same efficacy. But we don't use the first generation tricyclic for the anxiety. Only SSRI for anxiety. SSRI is approved for generalized anxiety disorder and as well as depression, including dysthymia or major depression. Efficacy is the same, mean you have to wait for 2 weeks. The same thing as buspirone that were approved for the anxiety, but it takes time, almost like just like the SSRI to see the therapeutic effect. Take about 10 to 14 days, but you can see there's some effect in the first 3-4 days. Efficacy is the same. For depression, as I said, tricyclic, SNRI, SSRI, amino inhibitors, they're all the same. As I said, that the first medication will improve the symptoms 60% of the time on the patients, and 30% will resolve this the depression, so that 1/3 of the patient after first antidepressive medication, they don't need to change medication or they don't need to increase the dose. That's what it means.
Thank you so much for clarifying my confusions here. So I have sent other questions, but I were right. Sorry.
Well, go ahead. You can ask. Go ahead, please.
All right. So is there? I mean, so you mentioned that for resistant depression, you use NMDA, right? Ketamine.
Treatment-resistant depression.
For resistant
treatment-resistant depression,
you use ketamine nasal spray, right?
First thing is to change the type of medication. The first thing is from SSRI to SNRI or bupropion. The SNRI like venlafaxine or the duloxetine. The first thing is to try to do to change medication to the different type of medication, not within the SSRI. Don't change from fluoxetine to paroxetine. It doesn't make sense. So you have to change from a SSRI to SNRI or use bupropion. And also the next step will be try to use 2 medications, either SSRI with the tricyclic, SSRI with the bupropion, but don't combine SSRI and the SNRI also, because they also block serotonin a lot. They can cause serotonin syndrome, which is similar to neuroleptic malignant syndrome. These are the steps that we will do. And the last step will be to augmentation with lithium, buspirone, or low dose of second generation antidepressant medication. Sometimes here, the doctors here, they are not patient, they don't have patients, so they just jump into the augmentation therapy after 1 or 2 medications.
Right. Thank you so much, Sarah. I want to know that ketamine laser and ketamine that we usually use for general anesthesia agent are the same.
Right.
All right.
Yeah, this is a hybrid of ketamine. Ketamine used as a general anesthesia. As ketamine, they don't produce the anesthesia-like effect, but they can increase the blood pressure. That's why the use is limited to treatment-resistant depression. But now the FDA approved for the treatment of depression itself, not only treatment-resistant depression.
Right.
And patient will wait about 1 hour to 2 hours in the office and take the blood pressure, so that to make sure that the blood pressure suddenly don't go up.
Right. And the another thing is, as a non-psychiatric physician, sometimes we are reluctant to prescribe SSRI because of the potential of the serotonin syndrome. So is there any specific way to monitor the earlier sign of the serotonin syndrome? Any very sensitive sign and symptoms coming first from the serotonin syndrome?
Usually with the average dose, say for example, fluoxetine 20 milligram, paroxetine 20 or 30 milligram, citalopram 20 or 40 milligram, or SI. These they don't produce serotonin syndrome unless you use a very high dose. Because of the obsessive compulsive disorder, we use high dose of SSRI. Like we use up to 60 to 80 milligram of fluoxetine a day. The OCD, we also use fluvoxamine. These medications are using high dose. And those are the times that you need to watch for the serotonin syndrome. And if you combine SSRI with some other medication, produces serotonin also. Not only antidepressant medication, other medication increases serotonin. So you got to watch for the serotonin syndrome. You have a lot of neuroleptic malignant syndrome in Myanmar?
Not really. But sometimes I mean, we are really reluctant to prescribe serotonin because of that thing. So it's now clarifying that it's a very less likely chance to start with the standard or low dose, right? So it's a good news for us.
Yeah, standard or low dose will not produce serotonin syndrome. Only with combination of two medications or very high dose, usually for a long time, then serotonin syndrome will cause serotonin syndrome.
Right. Thank you so much.
Are there a lot of practicing psychiatrists in Myanmar, in Yangon? I know my friend.
Not really.
Not much. So a lot of non-psychiatrists are treating depression, anxiety, or even psychosis. I went to Myanmar. Now they have a lot of psychiatrists now because I went to Myanmar in 2000. I went to Myanmar every year except this year here. 2017, I went to Denali. Denali means now is Yuadaji. I gave a lecture of three lectures of forensic psychiatry to psychiatric postgraduate training and professors. They're Dr. Tata E and the one from the UM1, Dr. Tata E, Dr. I don't know, I even lost, I forget the name. Three professors of the psychiatry and a lot of psychiatric postgraduate students, postgraduate doctors, they were there. Because in Myanmar, there is no forensic psychiatry training. They're not exposed to forensic psychiatry. When they go to court, they have difficulty dealing with the lawyers. That's why they gave me 3 topics to come and give them a lecture at that time, 2017. I'm not a natural lecturer or teacher. I'm just doing the psychiatry and forensic psychiatry, and a lot of times they ask me to do some talks and I had to try to prepare. Take me weeks to prepare the topics. But this was prepared before and give a lecture initially on at the Myanmar American Medical Education Society in New York City that I gave a lecture. I think in 2015 or 14, that time I gave the first one, or the similar one. Although I give a lot of them before, a lot of different topics. If you can think of any other topics that beneficial for non-psychiatric physician, please let me know. I'm prepared to try to give the presentation.
Right. I think we will create a voting system on internet, and we will when we get the votes, I will let you know later. And the another thing is right. Yes.
Is there any more questions?
There are some questions from the audience. So Dr. Tanto have one question, sir.
Okay.
Hi, sir. Nice to see you, sir. I have some question, but not about the medication. Your presentation is very easy to understand. Also, give us a lot of the information. Now, I have some question about this. As your experience in the U.S., would like to know about this the medication treatment and cognitive behavior therapy in the sense treatment in the psychiatric problem. Which one is more effective or we have to be a, do you think this we have to be a start with this medication first, or this cognitive behavior therapy? So I'm not sure for about this, and also I am not the expert in the psychiatric problem how to handle. Can you
Okay.
share your experience to us?
Yes, I will.
This?
For the psychosis and bipolar, the answer is medication. Psychotherapy is used only to understand their condition so that they can have better compliance with the medication. For psychosis, definitely there's no other way to treat patient than using medication, either the schizophrenia medications or antipsychotic medication or bipolar disorder. On the other hand, acute depression, you're going to start with medication to improve quickly. Depression can improve within a week to 2 weeks by using medications. If they are lucky, they get with the first medication, as I said, that 30% of them, they get in full remission, meaning that they don't change medication, they don't need to do anything. But for their own social problem, or the own cause of the causative problem, you need to follow with the psychotherapy. Because medication doesn't resolve all the issues. Medication improves the symptoms of depression, sleeping, energy, irritability, and they improve to the point that you can go back to work. You can go and function your own household chores. But to resolve the underlying issue, medication doesn't solve the problem underlying issue. So that you got to go through therapy, depends on how serious or how much conflict you have. It may be 6 months or a year or 2 years. So therapy is not the one that to initiate. Medication is the one to initiate. But the patient who do not need medication, not every anxiety or depression need medication. These are the ones that are not interfering with the social life or the occupational life. So you can just get by without using medication, because medication is helpful, but there are a lot of side effects. As I said, weight gain and other anticholinergic effects and serotonin effect, they are there. All medication has side effects. So either the small amount or to the large extent, to the small extent. But the one you don't need to use medication. That's why I decided if the patient needs medication or not. But in Myanmar, I'm not sure there are a lot of psychotherapists or not. In Myanmar, in mild, moderate depression or anxiety, you got to start with SSRI medication. And when you start medication, you got to advise the patient, watch your weight, and SSRI will interfere with sexual side effects 30–40% of the time. So, did I answer your question?
Yes, sir. Thank you so much. So this, we need to be clear what the kind of the psychiatric problem, and then we have to be approach which method is more effective for that psychiatric disease, right? So thank you so much, sir. Very clear for that.
Okay. So if you have any question that I can answer, even the not related to the talk. Yes.
Of course, Sarah, there are 3–4 questions which appear in the chat box from the audience. So the first question is from Dr. Ning Wei, which she asks is about what antidepressant can be safely used for pregnant and reproductive women.
I'm sorry, I did not hear the question quite clearly. If you want to tell them,
it's okay. I will repeat it.
I'm sorry.
Of course, I will repeat it, sir, again.
Okay.
So what? Yeah, can you hear me well, right? Okay.
Yeah, right. I can hear you.
So it's a question from Dr. All right. It's from Dr. Ning Wei from the audience. What antidepressant can be safely used for pregnant and reproductive women?
Or reproductive? You talk about pregnancy, right? Right. Or reproductive system means you're talking about effect on the ovary or testes or anything, or used during pregnancy. Which one is your question? As I said, sexual side effect means.
I think she mentioned about pregnancy.
Okay. All the SSRI, there's no contraindication using SSRI in pregnancy. If there's really need for it, you got to use it. But use careful, especially the first trimester before 16 weeks. It may cause some ADHD problem, sometimes very rare malformation, fetal malformation. So that's why we are allowed to use SSRI during pregnancy. But try to avoid, if at all possible, for past 16 weeks. But of all the SSRI, they found that the least, the medication that gives the least chance of fetal abnormality is S-citalopram. It's available in Myanmar, S-citalopram. We call Lexapro here.
I'm not sure about that.
Okay. I know you have a citalopram. I have seen it before. I came to have a medical mission twice. I treated a psychiatric patient in Magway Division, Magway State, a couple of times with the doctors from New York City. Is it a question? Reproductive system.
All right, doctor. Thank you so much, doctor.
I don't think there's any effect on ovary or testes, but sexual function, yes, it interfere with sexual function.
Right. And thank you so much, sir. I have another question from Dr. Nukai, which appears in the chat box again. So she wants to know about the fact, what is the safest antidepressant for geriatric patients?
Geriatric patient, you can use any medication, except the dose has to be low, especially people over 60, 65. You're going to reduce the dosage. Sometimes they try to avoid using tricyclic medications, the very old medication, like amitriptyline. I just remember the name now. Is it Dipta? I think it's called Tripta. Tripta is a 10 milligram. I look at it, 10 milligram amitriptyline that people take it for sleeping. I'm not sure if really 10 milligram can help them or not. But one thing different is between Caucasian and Asian is the Asian needs much less dose than Caucasian. When I went to visit the Yodaji, they told me that the average dose of the clozapine for patient to improve 100 milligram in Myanmar. In the United States, about 300 to 400 milligram. And they have more stronger enzyme system. The same thing I want to mention to you that when people drink excessively here, they came back for detox to the hospital again for 10, 15 years, they don't die. People in Myanmar, including some of my friends, they drink excessively and they die in 2-3 years. The alcohol dehydrogenase enzyme is not that strong, not that much in the Myanmar and other Asian people, but the Caucasian people can last a long time after even excessive drinking. So for the older people, they have a slower metabolism. You can use any antidepressant medication, except the tricyclics, use a lower dose.
Thank you so much, sir. And I got another question from the audience, who is Dr. Neeling Wu. So his question is, how to withdraw amitriptyline after 1 year use in insomnia patients, doctor?
Amitriptyline. That's what you asked? Medication? Amitriptyline.
Sorry, I think I lost you. Yeah. How to
withdraw from the antidepressant medication in general? I'll tell you. Yeah. Usually the rule of thumb here is after you have remission in the depression, medication should be continued between 1 to 1.5 years to prevent the relapse of the symptoms. When you withdraw in, you're going to cut it slowly in about 3-4 weeks time. Don't stop immediately because they have the depressive symptom may come back, especially if the patient is taking medication less than 1 year. So you're going to say that say fluoxetine 20 milligrams. You will have 10 milligrams for another week or 2 weeks. If available 5 milligrams, you can cut it down, or otherwise you ask them to use every other day. 10 milligram every other day for another few weeks and then stop it, so that it has a less chance of depression symptom coming back. It applies to not only amitriptyline, it applies to all antidepressant medication.
Thank you so much, sir. And another question from the audience, who is Dr. Mumin, is he wonders if he wonders about the role of electrocution therapy in psychiatry.
Electroconvulsive therapy, you mean?
Electroconvulsive therapy. I'm sorry about that. Yeah.
You're talking about ECT, right?
Electroconvulsive therapy.
Electroconvulsive therapy. It was quite popular.
Exactly, yeah. I'm sorry.
Okay, I'll tell you this, the history. It was quite popular back in 70s. When I was a resident, in first few years of become consultant, I give a lot of ECT to patients who have treatment resistant for the psychosis. Or the best result I get is with psychotic depression. Patients who are depressed became psychotic, you give them, I usually give them 3 times a week, Monday, Wednesday, Friday. And the rule of thumb at that time was, if the patient improved with 5 doses, you go to 10 doses and stop. But follow up with the antidepressant medication, because it may relieve the symptom, but if you don't follow up with the antidepressant medication, you may have a rebound of the symptoms. So, but what we have to do is at that time, even now, before we give ECT, we have to give the muscle relaxant. Because of the seizure, you know, sometimes they break the bone if it's severe seizure. Without seizure, the ECT is not effective. So we need to give them short-acting anesthesia and also muscle relaxant. But lately, because of the memory loss, I give at least about 40, 50 patients, none of them have memory loss, but there are cases that they lose a memory. But they always come back, even if they lose a memory. And people, the culture here is quite different now than 40 years ago. Anything that harming or anything affecting people, they don't like it. So it become very rare now. Only in our area, there's only one hospital giving ECT. And ECT is approved only when the other measure of antidepressant fails. Only that time that they use ECT. Still using it. We're still referring really treatment-resistant patients after 4 or 5 admissions and several medications did not improve. So we refer them to for ECT. But used very rarely compared to 40 years ago. Okay, this is the question. The answer you're looking for.
Of course, Doctor. Yeah, you answer very well. I'm sorry, I think I lost my condition or something like that. I think the connection is very not stable here.
Okay, is there any more questions? Ask me anything about the medical practices in the United States or even psychiatry. One thing is here in the United States, not like England or Myanmar. England also, all my friends in England, they are retired at 60 years old. Myanmar also says 60. We have no age limit here. If you're 90 years old, you can still work. You're allowed to work. You don't have no retirement age. Of course, but you become a retired person and get the Medicare at 65. But you can still work. You can still pay taxes. Here, the tax is so high. High means not as high as other countries, European countries or other parts of the world, but quite high enough. Even the tax pension, even pension I have to pay tax. Even if you win the lottery, you have to pay tax. I know that in Myanmar, if you win lottery or pension, you don't pay any tax at all. But here in the United States, you have to pay tax for everything you earn or you gain. I'm paying a lot of taxes. I have a retirement. I have a income from work, still pay a lot of taxes. You have any other questions?
Right. So thank you so much. Sorry.
I have still time.
Okay, right. So, Sarah, I got the last question from Dr. Mu from the audience, which appeared in the chat box. So can you hear me? I think I lost my connection sometimes.
Yeah, I can hear you.
Of course, thanks. So he wants to know about when to stop the medication after treating depressive and anxiety patients.
Or anxiety patient? Anxiety patient? So when you stop the medication?
Yeah, after, right. Yes.
Yeah, it depends on, also you got to look at what is causing anxiety. If the causative agent is removed or minimized, you can start to cut down on the medication first. And don't stop the medication abruptly. You got to see here we see the patient, the doctor sees the patient every month, sorry. Therapists we see every week. Therapists work with the doctors in the same clinic. They report to the doctor how the patient is doing. The doctor only manage medication and the symptoms. So they can coordinate and see that if the patient has ability to handle the stress, ability to handle the unpleasant situation, how much the coping skill that they have. If they are having improvement, so you can try to stop gradually from a regular medication, make it PRN. A PRN medication, the dose of each PRN dose can be lowered, also reduced, to see that if they can manage it. So as I said, that the use of benzodiazepine group of medications should be very careful, not to let the dose become so large that you cannot manage anymore. So that the dose of medication reduced and discontinued is based on how much patient can cope with the stress, how much patient can functioning well, sleeping without medication, energy, less anxiety without medication. These are the things that you have to consider. In absence of the therapist, you're going to talk to the patient about these, the one causing anxiety, the one stressful situation, how much stressful, for example, stressful job, stress with the supervisor. What you do about the stress with the supervisor stress with the supervisor. Or problem have husband and wife, how much they have improved, the conflict that they have improved. These are the things that you need to take into consideration before reducing the dose or stopping the medication. Look at how they function, look at how they cope, look at how much the problem has been resolved. These are the indications that you can reduce. Of course, stop the medication as soon as possible. I try to use, for any condition, any psychiatric condition, try to use the lowest effective dose. For psychosis, for bipolar, the lowest effective dose. So you have still a room to increase if required. So also easy to stop it when the dose is low. Any other questions?
Thank you so much, sir.
Okay, thanks for
the last one question, sir, please.
Okay.
I'm sorry. So Dr. Chen from the audience wants to know about whether transcranial magnetic stimulation is effective or more effective than ECT.
TMS, now transcranial magnetic stimulation. Yes, these are also used now. I have no experience with them, but one of the doctors, I'm not sure you know him, Dr. Pom Nguyen, he works with me. He was a professor of forensic medicine in Mandalay, and he also worked in UM1 as a lecturer in forensic medicine. He has a private practice. He uses the TMS. The effectiveness also, I don't think there is like a new magical medication. It's also some patients improve, some patients don't improve with the TMS. So it's not the, but esketamine has more chance of getting better as ketamine. But but any of the treatment-resistant depression cases, they become treatment-resistant, very difficult to treat, regardless of what you give them. As I said, most of the patients improve with 1 or 2 medications anyway. So try with the effective dose of medication, such as fluoxetine 20 milligrams. If you want to avoid side effects, you try to start with half a dose, low dose first. Fluoxetine 10 milligrams, especially in people in Myanmar, their tolerance to medication is lower than people here in the West. So that it's best to work, even though the book says that how much you have to start, you can start with half a dose. Even in the beginning, when we learned about fluoxetine, they said that the average dose is 20 milligrams, but 10 milligrams can also improve. If the patient improves 20 milligrams, 10 milligrams still improve about 75% of the patient. So they try to use a lower dose to start with. So so that you have room to increase, try to use a different type of antidepressant, combination of two antidepressant medication, augmentation, and only after that you think about TMS and the esketamine or electroconvulsive therapy.
Thank you so much for answering the question, sir.
Okay. Any more questions?
If you still have time, can we ask the last question from Dr. Mu Ling?
I have time. It's raining outside. I cannot play golf, so I have time.
Thank you so much. The question is, right, thanks, right. So how do you treat elderly patients with dementia or without dementia who present with hallucinations?
Dementia with hallucination is very common. Yeah, this is a question.
With or without dementia or with hallucination?
With or without hallucination, dementia with or without hallucination. That's the question?
I'm sorry. No, with dementia or without dementia with hallucinations, sir.
Okay, hallucination without dementia is regular psychiatric patient. Okay, we treat that as a hallucination without dementia is a psychosis. What psychosis it is? It's a brief psychotic caused by drugs, psychosis caused by other physical agent, medication. A lot of medication to cause psychosis. Because of anticholinergic effect and steroid also can cause psychosis. You treat the same way psychosis as you treat this the regular psychosis, antipsychotic medication. When it comes to dementia, what happened is that in the United States, people with dementia, when treated with antipsychotic medication, their mortality rate increased. Mortality rate increased from about, not that really much, but they are very careful here. I think that they increased from about 1.7 to 3.7 something, the mortality rate. Without antipsychotic medication, mortality rate is 1.7, and with the antipsychotic is 2.7 or 3.4. But it's a black box warning. That warning means it's a serious warning in every antipsychotic medication package that do not treat with dementia patient. But we have no choice. When the patient has dementia hallucination, what do you want to do? You can't do anything else. So we still have to treat the patient with hallucination or delusions with the dementia. Try to use the low dose. As I said, usually dementia happens in older people. we have to treat it. We have to use the antipsychotic. For the aggressive diabetes patient, the best medication is valproate. So give the valproate sufficient dose, the aggressive behavior will much reduce, or you can solve the aggressive behavior. But when it comes with the psychosis, you're going to use antipsychotic medication at a low dose. But try to stop it as soon as the hallucinations stopped or dementia stopped after tapering off. Same thing as all the antidepressant medication, you're going to taper off. So that's but dementia, when they happen, the first thing happen is depression. So you're going to treat the depression with dementia because they started to realize that their memory is not good, they had no ability as they have 15, 20 years ago. When they're aware about their dementia, the first thing is depression. Only when they cannot sleep or only when there's other causes, they become psychotic. And use a antipsychotic medication. Okay, that answer the questions?
I
Hello?
think he will be satisfied with your very good answers, sir. Hello. So I think he will be very satisfied with your complete answer, sir.
Any other questions? As I said, I have time. I'm not going anywhere today.
No.
Okay. All right. If you can think of any other topic, I will try to present it. If you can think of, this is a general overview of psychiatry with the common illnesses. Any specific thing that we can, I have presented bipolar disorder, mood disorder, forensic issues. The forensic issues is not the same as Myanmar because the law is quite different here than in Myanmar. But still, there are basic forensic things that everybody should know. If it knows doing, it's good. Anyway, as I said, I am not a natural lecturer. I never involved in teaching. But I try to make
anyway, the whole thank you so much, sir. The whole presentation was really going well, and that was really incredible. So, and the another thing is, of course, we will do the voting system for the another topic for the another lecture, and I will let you know then.
Yeah,
so
if you can,
anyway,
you let me know. Even most recently, last year, in MES in New York, Myanmar American Medical Education Society, I give the lecture on opioid dependency crisis. I'm not sure how prevalent in Myanmar. Here is pretty bad. People died from opiate overdose. About 67,000 people die a year in the United States from opiate overdose. Now all the police are required to carry Narcan, which is naloxone. If they think that patient has a opiate overdose, they're going to give nasal Narcan to save the life. That's how much bad it is here. Opioid. Only when I try to study also myself, I try to find out more about opioid and opiate. What is the difference? How do they come about? You use a fentanyl in Myanmar? Fentanyl.
Yeah. Sometimes, especially for the post-op patient.
Yes, we use fentanyl.
Yes. Fentanyl patch, right? You use a patch.
Especially for the post-op patient, yeah.
But fentanyl is not manufactured from the thing. They are totally synthetic. Most of them made in China. They imported to United States. A lot of people die from fentanyl overdose. Instead of they put it on the skin, they put it in the mouth. So the absorption rate is much faster, and they die from fentanyl overdose. Okay. All right. If you can think of anything, if I had time to prepare, I'll let you know. Okay.
Thank you so much, sir.
Okay. You're welcome. Okay. Thank you. Thank you for inviting me.
Nice, yeah.
So it will stimulate also myself also That's otherwise I go through everyday business things treating psychiatric patients. Okay, thank you.
So thank you so much for your time, knowledge, and the kindness, and also appreciate the attendees to participate here. So please let me request all of you to do the survey if you are okay with that, right?
Okay, did I talk too fast or not? I tend to talk fast.
No, I think it's okay. Thank you so much for the interesting topic.
Okay, thank you.
Thank you so much, Yai.
Okay, thank you. Thank you for inviting me. All
Thank
right.
you so much, Saya.
Good luck to everybody.
Thank you, Asia.
Thank you so much, yeah, and take care.
Okay, thank you. Okay, we can disconnect now.
Rest,
Thank you,
yeah,
Sia.
please.
Okay,
Good night.
thank you. Bye-bye, everybody. Good luck.
Bye.
Bye, Sia.
Bye-bye.
Dạ, tôi theo ý chứ mà dạ nó